venom? Venom. Okay. Venom is the bad guy, Batman. Spider-Man. Here, عشان هيك تصير كلمة غريبة. Okay. So بس مرات isn't venom really يعني? Okay. So they took the venom, they tested the extract of this venom, and they هذا العامل بالبرازيل probably he did not have enough facility to make his findings. He sent the sample of that venom to London, where his colleagues worked on it, and they found out that this venom or extract from the venom is an inhibitor of the angiotensin converting enzyme. So that started or developed the path for the use of angiotensin converting enzyme inhibitors in the treatment of hypertension. So let's review the renin-angiotensin system. مش مو عندكم السلايد بس يعني it's just picture. احنا بلشنا النص right? Okay. So when we have certain stimuli such as sympathetic stimulation, or we have decrease in the blood pressure, decrease in the sodium delivery through the kidney, this stimulates the kidney to release renin. Renin converts angiotensinogen into angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by the enzyme ACE. And these are the different effects of angiotensin 2. So some of them are pathological effects, some of them are just maintaining a normal vascular tone. So it causes systemic vasoconstriction. We have to remember, yes, angiotensin 2, we are treating it as the villain here, the bad guy, but actually we need to have vasoconstriction. We have to have a certain degree of vascular tone in order for these blood vessels to be able to pump, or not to pump, sorry, to deliver the blood to the rest of the body. But we have to have a balance between this constrictible or constriction ability and between vasodilators. Of course, we have the vasodilators, so we have homeostasis or balance between the two. Other effect stimulates the feeling of thirst, so the patient or the individual go and seeks water, and this can increase the blood volume. It activates the adrenal cortex to secrete aldosterone. Aldosterone have effects on the kidney to reabsorb sodium and water. In addition to that, it stimulates the pituitary to release antidiuretic hormone. لما يصير release antidiuretic hormone, this stimulates the renal tissue to reabsorb sodium and fluid. All of these effects are either going to increase the blood pressure or have some of the effects على changes in the structure of the blood vessels and the heart, which is what we talked about when we talked about the end organ damage, causing cardiac hypertrophy and vascular hypertrophy. So that means we want to try to stop the effects of angiotensin 2, not completely, but to decrease them in order for us to decrease the blood pressure. So one drug that we just mentioned هو an inhibitor of the ACE enzyme. So ACE converts angiotensin 1 to angiotensin 2. Angiotensin 2 will bind to the AT1 receptor. نحكي نلخص the effects. It's going to cause vasoconstriction and sodium retention. So the RAS pathway has multiple effects by a discrete pathway which are important in blood pressure control and increase the blood pressure. اللي هي السلايد اللي حطيناها قبل what are the different pathways activated. Now, ACE also converts, ACE is an enzyme. It also catalyzes the breakdown of bradykinin. Bradykinin is a vasodilator. So when I prevent its breakdown into an inactive peptide, we will have more bradykinin, so more vasodilation. So this aids us or helps us in our hypotension journey and what we want. We want to decrease the blood pressure. But this is going to cause an important side effect. Bradykinin are involved in immune reaction. So they're going to cause reactions similar to histamine release, similar to allergic reaction. And this explains some of the side effects we see with the use of ACE inhibitors. So what will ACE inhibitors do? They inhibit the conversion of angiotensin 1 to angiotensin 2, leading to reduction in vessel tone, sodium retention. It blocks the degradation of bradykinin, which is vasodilated. And studies have shown that they are very useful in diabetic patients, and they slow the progression of renal disease. So if I ask you what is a very good choice to use in a diabetic patient, it wouldn't be a beta blocker. It wouldn't be a diuretic. We didn't cover the diuretic, but we don't like to use them in also diabetic patients because they cause glucose changes and kind of insulin insensitivity. So if I bring you all of these drugs, the best choice would be the ACE inhibitor. What are these drugs? We have examples here. We have enalapril, ramipril, lisinopril, and captopril. Captopril will prototype. It has في صوت صدى مو سامعين؟ It has a sulfhydryl moiety. أي دواء بيكون فيه sulfur أو sulfhydryl moiety, usually it causes taste alteration because it interferes with the taste bud transmission there. So what are the differences between them? Do I want you to know anything? Any drug in general, مثلا enalapril is excreted primarily in the kidneys, so the dose should be reduced in patients who have renal insufficiency. بشكل عام, you probably learned that with kinetics. Any drug that's excreted from the kidney, you have to take very good caution in patients who have kidney problem. And we said these group of drugs are suitable for use in patients who are diabetics. Diabetes بيأثر على kidney, so we might worry about that problem. We have to adjust the dose. It's not a contraindication. Yes. Captopril, I think. So, what are the side effects? It causes severe hypertension in hypovolemic patients, especially in hypovolemic patients. It can cause hyperkalemia. Because we didn't learn about aldosterone, aldosterone will cause increased excretion of potassium. When I'm blocking aldosterone synthesis, I'm going to have retaining or reabsorption of potassium or maintaining potassium level. So this is a very important side effect we need to worry about. If I have a patient who have heart failure, it's very imperative to know what their potassium levels are. Or any condition, arrhythmia as well, we have to maintain levels of potassium and sodium within normal range. Another important side effect, it causes angioedema. شو هو الangioedema? It's rapid swelling of the nose, throat, mouth, larynx, lips, or tongue. زي تفاعل حساسية. And tackle only a small subset of patients, 0.1 to 0.5% of patients. It says here, it may be related to the inhibitory effect of bradykinin catalysis, but I do actually believe personally, I know it's written as that. No, it's more of an individual reaction because it is such a small percentage. But if we look at other side effects, cough and skin rash, look at the percentage here. It's 10 to 20% cough, and skin rash is 10%. So these allergic reactions can be mediated by enhanced levels of bradykinin. Well, cough can be so prevalent and bothersome to the patient that it makes some patients want to quit this medication. For one of the indications for changing or switching from an ACE inhibitor to another drug اللي ممكن نحكي عنه هلا اللي هو الARB, angiotensin receptor blocker, is if a patient have persistent cough that he cannot tolerate. يعني ممكن initially yes the patient will try to resolve that problem. I don't know how much it would work. And antihistamine will not fix the bradykinin levels. It's going to work at the histamine receptors. It is a kind of cutaneous, it will help. بس usually no, it will not resolve it إذا كان عنده persistent cup persistent يعني for a long time يعني حاول كتير وما عم بتروح يعني initially we try, yes, you might tolerate it يعني tolerance will develop for it within 2 weeks. If it doesn't, we have to switch them. Contraindications, yes. لا هو المين effect, so this is, it's not a very major effect على bradykinin على vasodilation, but it's gonna add. The major effect اللي هو through reducing angiotensin 2. Well, angiotensin 2 is a vasoconstrictor. This is the effect we're getting. But an additive value comes from more levels of bradykinin available. Side effects, no, these are contraindications. This can cause hyperkalemia, and hyperkalemia can be exacerbated. يعني تتضاعف أو شدتها تزداد with the use of potassium sparing diuretic. Example on potassium sparing diuretic, there are multiple, but one of them is an aldosterone antagonist. So the patient taking 2 drugs. Thiazides are not potassium sparing. Thiazides, they cause increase in the excretion of potassium, they cause hypokalemia. But spironolactone or eplerenone, as I told you, you're going to learn about these next semester, they are potassium sparing diuretic. Some studies indicate that the ACE inhibitors are not very effective in lowering blood pressure in the African American population. These are studies, and a lot of things with related to hypertension medications are the result of many clinical studies. There are big clinical studies, clinical trials, يعني thousand people across Europe or the United States to study, to compare the use of different antihypertensive medications for the control of blood pressure. And another important variable we look for, not only to lower the blood pressure. What's the problem with the blood pressure? حكينا increasing blood pressure. End organ damage. So most of the study, they focus on decreasing the risk of cardiovascular incidences or coronary heart disease, because this is our end target. You know, we want to have as low possible of these as we can. Pregnancy. With regards to pregnancy, because angiotensin 2 is associated with cell proliferation, we do not recommend to use ACE inhibitor in pregnancy, especially in the 2nd and 3rd trimester لما يصير في نحكي formation of the organs. Even at early stages, I wouldn't recommend it. Sometimes if the patient is used to it, we keep on her, but we try to move on to another safe medication. Now, what are the safe medications? We're going to talk about them towards the end. But beta blockers are used. Actually, they are one of the most common drugs used in pregnancy, but the safest drug to be used in pregnancy for hypertension ده بنحكي عنه اللي هو الدوبا, who you learned it last year. Yes. Probably for the high renin. The African low renin. Yes, yeah, عشان Now we're moving to talk about the angiotensin receptor blockers. زي ما حكيت أنا, I talked over and over. We refer to them as ARBs. What is different with regards to the ARBs? Yani, what do you think is going to be different? ARBs work as a receptor antagonist of this receptor. What's it called? It's AT1. Remember, one thing a lot of people mix up. AT1 receptor is a receptor for angiotensin 2. But why did we call it an AT1? Because we have another receptor called AT2 receptor. So what are these 2 receptors? So angiotensin 2 have 2 receptors, the AT1 receptor and the AT2 receptor. Both of them are receptors for Ang2. What's the difference between these 2 receptors? All the effects I talked about with relation to high blood pressure are related to the AT1 receptor. So once angiotensin 2 bind to the AT1 receptor, it can cause vasoconstriction, or it causes cell growth and proliferation. And this is very important in the structural changes that happen in the heart, in heart failure, and it's very important to the structural changes that happen in hypertension with a chronic high blood pressure. It causes aldosterone release, it causes central sympathetic activation, and sodium and water retention. On the other hand, the AT2 receptor have the opposite effect. So it causes vasodilation, it restrains cell growth and proliferation, يعني يقيدها أو يخففها. It mediates nitric oxide and prostacyclin release in the kidney, causes sodium excretion, and dilates afferent renal arterioles. It's the balance in my body. We said yes, we do need angiotensin at certain levels, and again, the effects of it are balanced through these two receptors. So instead of me just stopping the production of angiotensin by the use of an ACE inhibitor, we said, okay, why don't we block the bad receptor? And it's not a bad receptor overall, but in the case of hypertension, it's causing an increase in the blood pressure. So that's why we synthesize these group of drugs. One example, I think I have only one example, low sartan. They all end with sartan. And its effect is going to be similar to those effects of ACE inhibitors. So it's going to result in decrease in the total peripheral resistance, in inhibition of aldosterone release, in blocking sodium reabsorption. So pharmacologically, if you want to think about it from a logical perspective, we would think that yes, ARBs are much better than ACEs, then we are just blocking this pathway. But what do you think we should use? I'll go back to the slide in a minute. ACE versus ARB. We did not find a significant difference in relation to blood pressure lowering or to prevention of cardiovascular risk when we compare to these two drugs. So you can use either one of them, either ACE inhibitor and ARB in hypertensive patients who have heart failure, renal disease, and diabetes. One thing that can make the difference is the cost of the drug. Because these numbers are old. I think they're from study in 2005 or 7. حبة ACE inhibitor 11 cents. حبة احنا بنحكي مش علبة، وهداك حق الحبة من $0.50 ل 90 cents. Maybe they got cheaper, but there is a huge difference in the price. So if your patient is cannot afford the more expensive drug, and you know both of them are equally efficient in reducing the blood pressure, we would go with the ACE inhibitor. So we try the ACE first. What makes us change if the patient cannot tolerate the ACE? Because we said it can cause persistent cough, some patients develop angioedema for it, or other immune reaction. In this case, we have to revert for the ARB. If it doesn't make a difference, in the hospital, I think mainly they prescribe angiotensin receptor blocker because it's all covered under the insurance. Maybe the price difference is not as much as it is in the United States, so it depends, as we said, on the different conditions we have. Now, with regard to pregnancy, both of them are contraindicated in pregnancy because both of them will affect proliferation of cells through the AT1 receptor. So, not to be administered during pregnancy in either trimester. هون الفocus of the slide in the first trimester, the AT receptor is important in the embryonic renal development, but it should not be prescribed at all during pregnancy. Side effects also, low sartan or ARBs can cause angioedema, so that's why I told you maybe angioedema is not mainly related to the bradykinin level. It can be associated with the drug itself. Yes. Yes, عادي. لا هذول لو قبل بيوم او حتى يعني الفترة الأولى it's fine. She wouldn't know she's pregnant. يعني it's not as serious as ال3 سنين اللي كنا نحكي على الايزوتريتينوين وشو كمان حكينا تاع السرايسيس 3 years. روعكيوتان يس تاني في واحد تاني بس I forgot the name اللي هو بتاع السرايسيس. But it's from the same family. It was a retinoid as well. اللي هم الفيتامين A derivatives. We have 5 minutes more. So yeah, let's talk about alpha blockers because you already know about them. So the next group of drugs we will be talking about are the peripheral alpha-1 adrenergic receptor blockers. And these work in the vasculature where we have the alpha-1. But who can remind me what other kind of alpha receptors we have? Alpha-2, where is the alpha-2 present? Excellent, في الجانجليا أو في presynaptic nerve ending. What was, مين اللي جاوبني? What was the function of it, do you remember? It was inhibitory. So remember, we always have to have control in our body. Once there is two norepinephrine release, the body have different mechanisms to get rid of this excessive norepinephrine. One of them is binding to the alpha-2 receptor. It goes to the nerve endings and tells stop the release. So it prevents the release, the binding of that vesicle to the wall and release of further norepinephrine. And you remember all the other mechanisms of control of norepinephrine release, uptake mechanism 1 and uptake mechanism 2, and the other enzyme hormonamine oxidase and COMT. هذا أخذته بالautonomy last year. That's why they are important to remember, because some drug interactions happen when we have drugs affecting these enzymes or these pathways. فنرجع هلا على الألفا 1. الألفا 1 is different that we were talking about. الألفا 1 is in the blood vessels. It acts as, once norepinephrine binds to it, it causes vasoconstriction. This results in increase in the vascular tone. So once we use a drug called prazosin, prazosin is an inhibitor of alpha-1 adrenergic receptor on resistant vessels. It decreases vascular resistance, so it is a vasodilator. This leads to a decrease in peripheral vascular resistance again and blood pressure. أنا قرأتها مرة ثانية عشان أفكرها. So side effects is going to cause postural dizziness or postural hypertension. What do I mean by postural hypertension? يعني واحد فجأة يوقف، أكون أنا قاعدة أوقف أو your patient will be laying down, you know he's taking a vasodilator وأنت مستعجل تدخل المريض اللي بعده، so tell me يا بسرعة أو الممرضة does that, or anybody يعني أو he is in a rush, he wants to go and prescribe his medication, he might faint, especially if your patient is taking a vasodilator. هلا the good thing tolerance developed to this side effect in considering hypertension. So usually for this drug نسميها first dose phenomena. يعني with the first dose you see the highest degree of this postural hypertension. That's why we usually advise the patient to start taking the medication at bedtime. يعني أول مرة أول يومين ثلاثة when he start using prazosin to take it at bedtime because he's laying down, so we wouldn't worry about him having a hypertension and falling down. As with all vasodilators, it can cause headaches and drowsiness. What do you remember from last year? What's the main indication for the use of alpha-1 antagonists or blockers? ممكن نستعمل هون decongestion. I'll come back to that point, but an excellent thing to remind us with. Yes? في chromocytoma ممكن بس إيش تعمل؟ Excellent. Benign prostatic hyperplasia. Yes, these drugs are good at lowering blood pressure, but they're not the best treatment. مع إنه side effects of them are not a lot, but we have better drugs that are more efficient in lowering blood pressure. So we stopped using these drugs because we have the new groups of drugs that we've talked about in today's lecture and the last lecture. So the main indication for their use in clinics, and if you go to the hospital now, you're going to find a lot of patients above the age of 50 or 60 with prazosin or doxazosin or tirazosin. But their indication is benign prostatic hypertrophy. مين متذكر why? Yes. So, as your colleague Shusman Muhammad said, alpha-1 receptor is present in the prostate. It causes, if smooth muscle in the prostate, it's going to cause contraction of the smooth muscle, which puts pressure or constriction on urethra. Also, the bladder مش في عندنا sphincter وفيها also it has the alpha-1 receptor, so it's going to help relieve that constriction. So it's used to relieve inability to urinate or difficulty urination in patients who have benign prostatic hypertrophy. It's not treating hypertrophy, it's not treating the disease itself, it's treating the symptom associated with this disease. But why is this very important for us? As I told you, a lot of your elderly patients have prostate hypertrophy. They will be prescribed this medication. So if you want to give them another medication, let's say you are a cardiologist or you are vascular medicine, internal medicine, you want to give them a drug to lower the blood pressure, you want to make sure that he's taking a drug that can lower the blood pressure, vasodilator. So you want to give him a drug that's not going to interact with it or cause further deleterious hypotension. So what are the recent recommendations on alpha blocker? As I said, they are not used a lot nowadays. Alpha blockers are less effective than diuretics. Even diuretics اللي هم first line treatment in preventing the cardiovascular events, especially heart failure. This is according to a clinical study. اسمها approaches. أحكي لكم مش عم نتذكر الاختصار. Approaches to lower blood pressure lipids. We look at the cardiovascular events. هاي معنى الدراسة. بيطلعوا على الأدوية اللي بتقلل البلاد بريشر والأدوية بتقلل الليبيد and the effect of the use of these drugs on lowering cardiovascular events such as heart failure or stroke or myocardial infarction. Another thing, the NIH, the National Institute of Health in the United States, recommends not to use alpha blocker as the first drug of choice in hypertension. Yes, it is safe, but it's not as effective in preventing heart failure. So it is a reasonable addition to facilitate blood pressure control, but on its own, it's not a very efficacious drug. So we're going to stop here. Do you have any questions? Okay, thank you so much.